1 second. Okay, can everybody see my screen? We're starting on time today because we're covering so much information. Okay, first my terrible joke of the month.
Oh,
And
we can't see your slides. We can see his slides.
oh shoot. Okay. I am going to share my slides first. So funny because I could only see my slides.
You know what? I have two screens. There's
Yeah,
one screen
we
with your slides.
we can
Okay.
actually choose Amber's screen too.
Yeah, I can choose your screen. So, okay, I'm good.
Okay. And everybody's AI is asking to join, which is so funny.
Actually, I can't see Amber your screen. I see only Gia's screen.
There's two screens at the top. The one on the left is Amber's.
All right, yeah, sure.
Yeah.
I've never seen that before either. So
No, not me either. Yeah, thanks so much. Yeah, great, thanks.
New technology just for us. Okay, with
Okay.
everybody.
Okay, and of course, good morning, everyone. Good morning
I think
to
he's
those
starting.
who are in the States, and good afternoon, Kai. Happy to see you. To those in Europe, it's really my great pleasure to be here with you, with clinicians, researchers, families, and advocates who are in the heart of this community. Amber, I have no word to thank you. Thank you very much for inviting me, and thank you very much for the great job you have been doing perfectly and to move the, let's say, field forward and to help those affected. Thank you so much, Amber. Appreciate it a lot. And today I will be sharing our experience using acetazolamide as a treatment for drug-resistant epilepsy in SLC6A1 related disorders. Our cohort is very small. We have only 5 patients in our cohort, but preliminary results are very promising, and I would like to share them with you. And anything follows our previous work in CHD2 related epilepsy. Where we published similar findings. And you see, after publishing in Epilepsy Open, it happened in August 2024, we have received a lot of emails, you see, around the world, and from families, from colleagues, and most described very remarkable success on acetazolamide in CHD2 related epilepsy, with only few where acetazolamide did not work. And you see, it highlights for us something, you see, something important, because when treatment shows real potential, we have an ethical duty to share it, you see, with families, caregivers, with colleagues, even when evidence is still emerging. That's why we decided to share this information, this preliminary with very small cohort, this finding with you. And you see, I am very excited because
Gia, you're breaking up a
now
little.
launching a global and sorry.
You're breaking up just a tad bit. You sound better now.
Okay. I was talking that CHD2, QRCHD2, it's parental organization launching global study on to formally evaluate effectiveness of acetazolamide in drug-resistant CHD2 related epilepsy. And goal of this study would be to make acetazolamide as a treatment option, first option for patient with CHD2 related epilepsy. And again, thank you all for being here. And I would like to say many thanks to my collaborators and friends. Many thanks to Professor Olivier Dulac, he is not here, to Professor Pasquale Striano, to Professor Kai Kaila. Kai, happy to see you here. And all my team here in Tbilisi. I would like to make special thanks to Professor Ben Zebrurian. Amber, it's your deserve that she contacted us and she involved in our study. Many thanks to her. And I would like to give special credits to Professor Kai Kaila. You see, he's eminent expert in the field of GABA neurotransmission and in carbohydrates. His lab in Helsinki has started a project on the mode of action to evaluate mode of action of acetazolamide in CLC 6A1 related disorders. They have, I don't know even single lab having such kind of experience. You see, in decades of working on carbohydrates, on GABA neurotransmission, and their experience in preclinical work, in vivo, as well as molecular, cellular level, very high input from them.
Thank you, Guillaume.
It's reality, kind, and I wanna stress it out. Now let's go further. And as you see, our talk about effectiveness of acetazolamide is CLC 6A1 related epilepsy. I would like to show you table. And as we can see, there are 5 patients, all are females. With drug history, treatment history, with a lot of conventional anti-seizure medication used prior the acetazolamide. All of patients had myoclonic seizures. 3 of 5 patients have myoclonic atonic epilepsy. And also most of them have atypical absences. And all of them were drug resistant. And I would like to show you efficacy of acetazolamide shortly. It was our, let's say, we excited to show you that 3 out of 5 patients got full remission. It's very amazing, you see, very remarkable. Only 1 patient, it's also responder, but more than 50% of seizure reduction. However, this 5th patient, it's upon physician's decision. They did not go to rise the dose of acetazolamide. What else I would like to stress it out? I mentioned our previous study on CHD2 related epilepsy, and the median dose there was 2 times lower than dose needed to control seizure in CLC 6A1 epilepsy. I will show the slide. It's slide known for everybody there. I would like just to tell you that 3 out of 5 alteration was in transmembrane protein, and 2 alteration happened in extracellular loop. And median dose was 16.1 milligram kilogram day, and to opposite to CHD dose used in CHD2 related epilepsy, there was 9.2 milligram per kilo. So it's very hard to generalize our finding, but let's say as a preliminary view, we need higher doses to control seizure in SLC 6A1 related epilepsy. Almost twice more dose than in CHD2. I would like to show you EEG. there EEG of 2 patients. EEG, it's before acetazolamide. They are clearly seen photosensitivity on intermittent photic stimulation of 9 hertz, 8 hertz, sorry. And on treatment on acetazolamide, the same frequency of stimulation, there is nothing, you see. And photosensitivity and epileptiform discharge disappeared fully. And second patient also, there is intermittent photic stimulation on 16 hertz before acetazolamide. And now we can see that on the same frequency stimulation, all the discharges disappeared. So as a summary, out of 5 patients with disease-causing SLC6A1 variants, 4 respond dramatically well to acetazolamide, including 3 with complete remissions. Acetazolamide was well tolerated and no adverse effects were reported. The mean dose of acetazolamide was 16.1 milligram kilogram day, and which is approximately twice as high as that previously reported in CSD2 patients. And 5th patient did not reach the median dose. And caregivers also reported improvements in behavior, sleep, and ataxia. Summary again, from our very small cohort, it appears that acetazolamide appears to be a safe and effective treatment option for drug-resistant SLC6A-related epilepsy. And it's very hard to generalize of our finding, but preliminary results are very promising and warrant further investigations. Now I would like to, let's say, show you we found very interesting, you see. SLC6-1A1 is one of only 3 monogenic causes of myoclonic atonic epilepsy, along with the next myth, also known as KAA 2022 and SYNGAP1. Both these genes are believed to be causing, in some extent, they cause a phenotype of myoclonic atonic epilepsy. And surprisingly, you see, and I would like to, let's say, stress out, and I would like to share some information about NETRE network. NETRE is network for, let's say, drug-resistant epilepsies. It's mainly the doctors around the globe are participated in this network. And we have received a lot of correspondence from colleagues from this network. And both genes, you see, SYNGAP1 and NextMIF, also known as KAA 2022, respond very well to acetazolamide. It was surprised us a lot, you see. Secondly, you see, there are also 2 other genes. One gene also included in RABIC-T study, you see, STXBP1. And second gene is STX1B. And both genes are involved in GABA neurotransmission machinery. We have our own cases with dramatic response to acetazolamide. And also our correspondence within the NETRE, also our colleague reported good response to acetazolamide in myoclonic atonic epilepsy, which caused by those 2 genes. It's very interesting, you see. So there are a list of genes we have already found. We have, let's say, one case or 2, 3 cases where acetazolamide worked perfectly. So these genes are, all of these first 3 genes are genes for myoclonic atonic epilepsy. There are SLC6A1, NextMIF, SYNGAP1, and STXBP1 and STX1B are involved in GABA neurotransmission machinery. Also with very good response. We have our own cases. That's why I'm very sure that in our cases, acetazolamide worked dramatically. Especially when we are talking about STXBP1, with, let's say, I would avoid this word, but with catastrophic epilepsy, you see? And acetazolamide worked very well in our patient. What interesting, we found very interesting. You see, there are primary episodic ataxia. Let's say so far we can list out around 10 causes, 10 primary episodic ataxia. And among episodic ataxia, some have disease-causing genes, and some don't have gene, let's say, discovered so far. But most of episodic ataxia are responsive to acetazolamide. It's also very interesting, you see. And we would like to stress out that where is converge point, you see, for these 3 independent at first glance you see. One condition is myoclonic atonic epilepsy. Second, 2 genes are involved closely in GABA neurotransmission machinery, and also genes as disease-causing genes for episodic ataxia. All are responsive to acetazolamide. What is converge point? We were thinking about it, and we let's say we left room for improvement for basic scientists. You see, because ataxia is the feature we can observe in all of these 3 conditions, and we can speculate that cerebellum could play a crucial role in pathogenesis, and maybe cerebellum is target for therapy for acetazolamide. We don't know, but it's let's say we will find out the answer for this question. It's very important question, because it will open the huge room for improvement for many monogenic epilepsy, you see? And especially when we are dealing with drug-resistant epileptic encephalopathy. That's why we found it's very, very, let's say, excited, very amazing work to be done. And again, we looking forward to hear your talk, Kai, my friend. This talk will happen on June 10, as far as I know.
Yeah, that's the plan, yeah.
Yes. So, thank you for your attention. That was my humble presentation. It's very small number of cases. And I would like to thank Amber once again for everything, Amber. You have been doing, let's say, I even cannot explain what you have been doing for children, for your community, for children affected by SLC6A1. Thank you so much.
Thank you so much. One question I know a lot of the patients are going to have is what you think of taking this drug in combination with Ravicti or a supplement similar, like just butyrate or sunbutyrate.
You see, we have searched all the publications about Ravictin, and we should anticipate that the both drug could cause acidosis, you see. And as far as I know, the patient who dropped out study Ravictin, there is only one patient who dropped out, as far as I know, and he or she dropped out due to acidosis, you see. That's why I would be very careful to combine these two drugs, because acidosis is also one of predictable side effects we could predict or can anticipate while using acetazolamide.
I put a paper in the chat for you guys. You might find the answers in there. Apparently, this drug has been used for a very long time, and they saw a decrease in epilepsy in 607 patients over multiple studies since the 50s. So this may be a generalized effect of the diuretic on epilepsy. And maybe there's combinatorial studies in there. I'm pretty sure there are because I just looked at the paper briefly. So there might be other drugs that those people were taking at the same time. You might find information about that.
Yeah, yeah. And you know, there is no regulatory limitation to use this drug because FDA approved this drug.
Mhm.
And also European Medicinal Agency approved this drug for using as add-on treatment in epilepsy, especially in absence epilepsy. And our patients, our children with SLC6, A1 related disorder, their epilepsy type mostly are generalized one, myoclonic,
Mhm.
atonic seizure, atypical absences, and there is no regulatory limitation to use this drug, especially in the drug-resistant cases. And it's very cheap, very, let's say, reachable everywhere.
And Kim Nye has an interesting comment that the drug has been used for her child's condition in the SLC 13A5 community, which is
Yeah.
a citrate transporter. And they've taken that in combination with other seizure drugs.
Yes, my guess is we are dealing with new, let's say, new avenue for the epilepsy pathogenesis and treatment, you see. And I strongly believe we will come out with very successful findings. And it will be evident, you see, that acetazolamide could be used at least for some monogenic epilepsy with great success. I
And
strongly believe.
will say that Maxwell tried it and it became slightly acidotic, but I would reconsider it. Just know that and perhaps take it in combination with some I'm I'm blanking on bicarbonate. Do I have that right? Okay, yeah,
Yeah.
just take it in combination from the beginning because some kids are just a little bit more sensitive than others, and um it's it would be possible.
Amber, I would like to share with you some my clinical experience. You see, first of all, acidosis is what we are seeking for, you see, because we know that inhibitors of carbohydrates, they will cause acidosis, you see. The most important not to go out from the range, because we should and we must expect acidosis. And At some point, at some extent, acidosis is the reason that these drugs are working. And I would like to just to tell you the story about ketogenic diet. When at first our pediatricians were so afraid of hypoglycemia. Even when glucose level was 40, it was panic here, you see. But children are compensate very well. They are doing very well, you see. And if there is no clinical signs of, let's say, hypoglycemia, or there is no clinical signs of acidosis, there is no problem, no worry about, let's say, this drug. Am I understandable? I would like to stress out this because sometimes it's very, let's say, sensitive for the parents, for the doctors who are not familiar with ketogenic diet either, or with using inhibitor of carbohydrates. The most point that this level of this acidosis must not exceed this range, this therapeutic range. Yeah.
Yeah, hi. This is really nice. I saw from the website in just from Google. So that drug can be used for glaucoma, epilepsy, like a mountain sickness and fluid retention. So maybe it's because of the cells of edema. Or yeah, this is my first question. So it's because this will help the cells regain homeostasis and reduce some water volume. Second, you said like acidosis, the range is very just keeping a right range. But in clinic, the kids dropped for example, for both Ravicti and this drug because of acidosis. Can we prevent that? Is it easily preventable? Just to give another drug, as Amber said, bicarbonate to reduce the chance for acidosis.
If I can comment on this.
Yeah.
So, right, so I wouldn't worry about the acidosis too much. It's anyways like, well, acetazolamide has been used in pediatric patients, and it's probably going to be used in neonates as well, so very soon. So, and one of the therapeutic like aspects of acetazolamide is exactly the acidosis, like Gia said. The other thing is that in the brain you have like tens of different carbonic anhydrases, isoforms. So they are like a mosaic in the brain. And of course, like clever targeting of certain types of like carbonic anhydrases would be cool. But I mean, it seems that like this systemic application of acetazolamide is really efficient. I mean, it couldn't work better, Gia, right? I mean, it's like almost like ideal. So and maybe yeah, as an like a second line drug, it probably was also is very useful. One more general note, if I may. So it seems that design of epilepsy drugs has been largely misleading by or misled by sort of naive concepts of excitation, inhibition, balance. We should all be like kicked out of the window. So it seems that GABA is an excitatory transmitter under many cases. Just by stimulating interneurons in the cortex, you can evoke seizures. And there's a lot of like, I mean, if somebody's interested, I wrote with some other guys. I wrote a pretty extensive review in the Jasper's book on how actually GABA can and does drive seizures. So we should change the whole concept. Like it seems that pro-GABA drugs, GABA-enhancing drugs, are pretty harmful often. Like they have side effects which you wouldn't like to have. And yeah, and I subsume, but I mean, it seems that totally like novel modes of action, like with levetiracetam, for instance, you have like a suppression of both glutamatergic and GABAergic transmission. Still, you get a really nice anti-seizure effect in many patients, many patient groups. So this is like a completely new like opening for devising new approaches for epilepsy and seizure therapy. Doesn't have to be epilepsy, but seizures. One more, if I may. What I find really interesting with this, like this patient, like class, which Gia was talking about. Yeah, it's that actually there. So the paper. Yeah. So I saw it's in the chat. So is that so many genomic changes lead to the same outcome. And if you look at, for instance, autism literature and transcriptomics of autism, you see amazing convergence of similar phenotypes. And there seems to be like a big gap between current transcriptomics and clinical science, which should be filled as well. So I mean, there's so much to do that in this like completely new ideas in this field. It's really exciting and hopefully really fruitful for the patients as well. Okay, I'll stop my mini lecture here.
I agree with your mini lecture. And one of the foci of my lab is to use previously approved drugs to screen for anti-seizure compounds in Drosophila. And probably the strongest one that we've published, and you can look it up, is an antidepressant, actually several antidepressants. So I just want to speak to what you said, and that is, you know, as a clinician, you use drugs A, B, and C to treat epilepsy because those are the drugs you used, right? Those are the ones they told you to use, right?
Yes, exactly.
So no one's taking a kid who's seizing and who has pharmacoresistant epilepsy like Dup15q and then giving them an antidepressant. It just isn't happening, right? It's not the phenotype you're treating. So when they work, it's a surprise, but at the same time, we shouldn't be surprised as a scientific community because we have all these drugs that we could be using right now off-label, as you mentioned for this drug. And we're not using them because we don't have the scientific evidence that we should be using them, right? So that's really the crux of what we do in my lab and other labs should be doing,
That's cool.
looking for new compounds, right?
That's cool. Yeah, I think, because I mean, I think this sort of like categorizing drugs just on the basis of indications is a road that leads nowhere. Actually, it's a very stupid road.
We know it doesn't work because we've been.
And this is actually this is absolutely something that preclinical research should look at, like because I mean you can do anything you like, almost like drug-wise in experimental animals, but not of course in patients. But really, I think there's a massive laundry needed in this area, like the whole and so and I repeated like I get sick with these excitation inhibition balances or NKCC1 KCC2 balances. I think they're back to the Greek time of Hippocrates.
You might want to look at one of our papers because glial cells are involved.
Yeah, sure.
That's all I'm going to say.
Yeah, sure. And then this excitation inhibition balance thing is total rubbish. I mean, like really.
You might agree with that and take a look at it.
Yeah. Okay, Michael, is there?
Yeah, I just wanted to point out that on the same idea that Larry is talking about, topiramate, which is a well-recognized anti-seizure medicine, has a variety of mechanisms, but one of its actions is as a carbonic anhydrase inhibitor.
Yeah.
So I'm wondering whether that's been tried in SLC6A1. It is a drug that's effective for treating generalized epilepsies. It has a broad spectrum activity, so it would be interesting to see if it might work in this condition.
Yeah.
In two of our patients, topiramate was used, but without success. I don't have explanation why the same class drug did not work, but that's the fact that topiramate was used in two of our patients. I don't know why. Even zonisamide was used without success. There might be some differences between those drugs. You see, having the same label as being carbohydrate inhibitors, but difference is very huge. I would like to stress it out from the clinical point of view,
Right,
but
Michael,
no
if
explanation
I
so
may,
far. I'm sorry.
yeah, no, so, by the way, should we ask for, I mean, Amber, are you chairperson here? Like, can we just like talk freely into? Okay,
Yes.
okay. So, Michael, do you know of any case where it has actually been shown that topiramate carbonic anhydrase inhibitory action is its main, I mean, its prominent action in seizure suppression?
Well, the problem is that topiramate has a variety of actions,
Yeah,
and I don't
exactly.
think we really fully understand which of those actions is responsible,
Yeah,
as you say.
yeah,
But it's very clear that it has carbonic anhydrase activity, but
that's true. Yes, yes.
it's not as potent as that of acetazolamide.
Yeah, right.
So,
Yeah,
yeah, acetazolamide is much more potent. Of course, it's a pure carbonic anhydrase inhibitor. But I mention it because Larry had pointed out that oftentimes you could repurpose drugs for different purposes, and this is one of the actions of topiramate.
yeah,
You know, one other thing I would mention and ask the group, and that is that one of the problems with carbonic anhydrase inhibitors is that tolerance tends to develop. They may work in the beginning, and then you get presumably restoration of the acid-base balance, and they stop working. And maybe you could go on a holiday for a period of time and then come back and they will work again. And I wonder whether that experience has been the case here for the treatment of these genetic conditions.
May I answer? Okay. You see, you're right. There are a lot of literature stressing out that tolerance is very often happens when we are using acetazolamide. However, according to our own experience, let's say we have a cohort of 14 patients with CHD2. In only one case is tolerance developed. In only one case is because we have several patients who have been taking acetazolamide for 1 year, 2 years, even for 4 years, and the tolerance does not develop. And that's, I don't know why, because in all the previous literature, they are stressed out that it's very often happens while we are using acetazolamide, but our cohort says different things. You see, it's very rare when we can deal with tolerance.
right. Can I, Michael? I mean, you have such broad experience, so this tolerance is again, it's like repeated over and over again in the literature.
I am sorry, Kai. One thing, very important thing,
Yeah.
because patient from the Professor Ben Zevi, Pruria,
Yeah,
has been taking acetazolamide for 11 years. Can you
yeah, yeah,
imagine?
yeah. This
11
is
years without
exactly.
any tolerance. I'm sorry for disturbing you, but yes, sorry.
Disturbing. Right, great contributions. But hey, yeah, Michael, I'm really like I've been always like puzzled. I mean, about this like almost like this sort of like tautology. Like I mean, acetazolamide is an old drug. It leads to tolerance, and then I don't find the papers. And then I hear from clinicians, for instance, I recently talked to a prominent neurologist in UK who said that his colleague had put a patient who had been a TLE patient who had been on acetazolamide very happily for many years, said that that's an old drug, let's give you something better. She was dead in a week.
Hmm.
So that's for tolerance, at least in that case. So then there's so many, like, I mean, you know this better than I do, so many different types of epilepsies, different spectra of drug action. So is there really such heavy evidence on tolerance regarding acetazolamide? Or is it just something that clinicians like to repeat all the time? I'm not a clinician.
Well, one thing that I do recall is that the anti-seizure effect of topiramate does not show tolerance, but I believe the acidification that occurs with acetazolamide does show tolerance. And so people have concluded that the mechanism of action of topiramate is not exclusively anyway due to an effect on carbonic anhydrous, that there should be other mechanisms of action.
Yes, absolutely. Yeah. But what about acetazolamide?
Yeah. Now, the other thing I should mention is that, acetazolamide has been used in epilepsy, as has been pointed out for a long period of time. The one place where it's maybe still used occasionally or where it's been proposed to be a useful treatment is in catamenial epilepsy. So catamenial epilepsy is exacerbation of seizures at specific times in the menstrual cycle,
Mm.
specifically at the time of menstruation. And the idea here is that you could give it just during that specific time, and then tolerance wouldn't develop. If you gave it chronically all the time, you'd get this tolerance phenomenon. But because catamenial epilepsy, the vulnerability is just during a specific time of the month, you could start the drug during that specific period of vulnerability and stop it, and so the tolerance wouldn't be an issue. But
Right, but I mean, my point actually is the tolerance an issue generally? I mean, how many papers are there, studies showing that tolerance is being like generated in a patient, unlike with other, more often than with other anti-epileptic drugs? Where's the evidence?
well, yeah, Kai, I'd have to go into the literature to look for that. But I mean, it is a generally accepted concept, and that's why I say it tends to be used exclusively for catamenial epilepsy, where there's a
Yeah,
specific
you're right. Yeah,
period of vulnerability.
yeah, yeah. This is like, I mean, yeah. There's so many conventions. Like, I mean, for treating neonatal seizures with phenobarbital, although everyone knows basically that phenobarbital is extremely harmful for the developing brain. And actually, it's obvious also from, I guess, from human studies, but it's sort of a hush-hush thing. So it's still the first line treatment for neonatal seizures, and it has been there for, I guess, before the FDA was, by the way, existed. So it's a really old and very harmful drug.
Yeah, and what's
Yeah,
so interesting about it is that it was one of the few drugs that was grandfathered, which meant
yeah,
that because it was
exactly.
before the
Yes.
FDA had a rule that drugs that were in common use before the agency came into existence, they kind of left them on the market. But
Yeah.
it turns out that just a couple of years ago, um, a um, a generic company submitted the package to the FDA, and now it is approved actually
Yeah. It is. Yeah.
for neonatal seizures. But to your point, it's very hard to do studies in neonatal seizures,
It is.
and
It really is. Yeah. Yeah.
so it is the drug of choice, just simply because there haven't been studies of other agents.
Yeah. Right.
Not to get too far off track, but you know, we learn a lot when we look into the past. I mean, I think some of us know this. So one of the screens that we did came up with a contrast dye that suppressed epilepsy in our model, which intrigued me. And I looked into the literature and found out that lo and behold, at the turn of the century, the last century, contrast dyes or dyes in general were used to treat epilepsy. So, I mean, sometimes you find that things that we think don't work or historically, they used to work or they're old drugs, this would be a situation where there's a drug that maybe the clinicians have heard of, but they didn't look through the literature. They didn't look through all those papers that I put in the chat, and that, so, I think now is a good time for us to repurpose. I mean, I'm a proponent. So I think we do need to sort of change our attitude about treating epilepsy in general and stop treating excitatory inhibitory and start using drugs that effectively treat seizures, whatever the origin, right? Methylene blue. Interesting.
We cannot disagree with your, let's say, proposal. Of course, we should treat seizures.
So it's something important to mention is that we are trying to recruit clinicians from around the world that are interested in participating in GIA's study and publication to give their thoughts. We've had some pretty good success. We've also had word of mouth around the SLC 6A1 community. If you can think of anybody who is interested in learning more or would even like to attend these meetings, please put me in touch with them and I can add them to the email chain about this topic.
Okay. Thank you, Amber. Thank you. It will be great. Thank you.
Yes, and just a couple other, does everybody feel like we're pretty good on this? Any more questions?
Yeah.
A couple other announcements from the SLC side. I wanted to ask if anybody is new to the call today or if anybody wanted to introduce themselves.
Amber, from our side, I would like to add that we will have a meeting with Professor Striano at the end of this month. And I think we will be able to add something important while Kai's presentation in June 10. As far as I know, your presentation, Kai, will happen at June 10. Am I correct?
Yeah, although I can't promise any SL6A1 data June. Mainly just basically what pH and carbonic anhydrase do in the brain. But we don't have, at that time, we don't have any, I mean, it's a new project. We don't have any, at that time, anything I would like dare to present in public.
Probably we will have some news and we will add to your presentation, well, let's say some short talk. And
Yes. Yeah,
we
absolutely.
will
Yeah, sure. Yeah.
be happy
Because
to add to your presentation some new information.
that would be great. Yeah.
Yes.
Absolutely. Yeah, sure.
And we will be happy. It will be our honor to, let's say, we will be happy to receive any questions and emails. And we will be involved as much as possible to share our experience. And we are open to any questions. Without, please.
Actually, I have
Without.
one more question. So I wonder, do you know anyone have ever have a combination use the drug with ketogenic diet? Do you have like a synergistic effect, or you have yeah, they have the clinical data?
I am sorry.
Yeah.
Can you please
So
repeat?
yes. So I'm curious. Have you ever, or if you know anyone has conducted research on use a combined approach of ketogenic diet and acetazolamide with the drug? Do we have a better effect if we use this in combination, or it's the same?
So far, we have not used these two approaches simultaneously. And it does not happen so far. So I don't have an answer to this simultaneous use of these two approach. However, let's say as it was the case for rabbit team, because both approach could cause acidosis. We should be very careful while use these two, let's say I would call approaches simultaneously. I don't know. I have no precise answer, but just anticipate that both approaches could cause acidosis, you see, and sometimes acidosis is the thing, the reason of dropping out from ketogenic diet.
Yeah.
I have a very fast question. So I remember that in the presentation that you did in September, you told us one of the variants. I'm curious about to know the list of the variants where acetazolamide works. Because as I've written in the chat, I believe that there is a relation between the position of the mutation and the changes of SSE6 to pH sensitivity. So if you can share, or maybe by email, or what are the variants where acetazolamide works, it could be quite interesting for me because I work on from the cellular point of view on the protein.
Elena, first of all, I'm happy to see you here.
Okay, thank you.
Because we have met, it's again Amber's desire. We owed Amber that we met. Of course, I will send, because even in my presentation, there are all the variants listed out. There is 5 variants. And I will send just right after our meeting finished, I will send the variants and all presentation to you with great pleasure.
Perfect, because I was late to the, probably I lost the first
It's
slide
okay,
because
Elena.
I have
It's
another
okay.
meeting before, so thank you.
I will send right after our meeting finished.
Okay, perfect.
Yeah.
So can I ask, Elena, is this actually, do you mean that manipulating pH would make that protein like functional?
Yes, because there was a paper of many years ago about GAT1, and I think there are more than one where there are GAT1 is not pH dependent, so it works similarly between 5.5 to, this is in the oocytes, because I suppose also in cells is the same, from 5.5 to 8. But if you change some amino acid, especially in close to transmembrane 10, it became more pH dependent. So it works better according to what the mutants that you have. It works better at pH 8 or pH 6. And so it could be that these variants can beneficial of the changes induced by blocking acetazolamide, because change the pH outside. And the other hypothesis instead is related to carbonate or bicarbonate.
Yeah, well, I somehow have very difficult to understand how that would work, like at the protein level. So to resurrect this mutation like into a wild type like molecule, well, I would find it very hard. I mean, conceptual.
I think that in the short presentation of our group of 1 month, more or less 1 month ago, Tiziana Romanazzi, my postdoc student, shows the results of one on this mutant. So I don't know if Tiziana is present, maybe she can find that slide that reports this huge pH dependence of.
Yeah, hello to everyone. One of the data that we find was that the mutation A288V was no pH dependent, like the gut-wall type. Instead, the A305T was pH dependent, showing an increase of the GABA-associated transport current at basic pH, not at acidic.
Okay. Goes a little bit like opposite to the acetazolamide story, which we know about.
But one of my questions is there are papers or other reports that show how the external environments change when this carbonic anhydrase is blocked. When what is going to block acetazolamide, and so consequently, what is the changes in the pH? Because you talk about acidosis, but are you sure of that, or?
You see, the best answer we would expect from Professor Kaila. However, we have been evaluating several possible pathogenesis, like BK channels, involvement of BK channels, involvement of aquaporin 4, because there are a lot of papers telling us that acetazolamide could be work as aquaporin 4 blocker. There are also hypotheses that acetazolamide could be agonist of R-type channel. However, after very deep discussion with Professor Kaila, we disregard this hypothesis, and let's say what we will find out, because the evidence supporting this hypothesis and this mode of actions is very weak.
Yeah,
But
if I may comment on that, I mean, the aquaporin story is clearly wrong. I mean, there are people who are like Walter Boron in the States. He's able to measure actually aquaporin mediated CO2 fluxes, and acetazolamide does nothing to them directly. There can be metabolomes, of course, but that's a different point then. All these calcium currents are enhanced by acidosis. And coming back to the carbonic anhydrase effect, you can have like a critical microenvironment around critically located carbonic anhydrases. So it doesn't have to be a lump, like massive, like acidotic effect. The targets can be pretty like discrete and well defined. And this is actually what I'm trying to go after. The acidosis per se will decrease excitability via many mechanisms, but there must be something else as well.
And everybody, we are at time. Thank you so much for the great discussion. It was great to see you all. And next month, we will have a presentation led by Dr. Franco Lombini from the Bossi Lab. Have a great week, everyone. Bye.
thank you, Amber. Thank you, everyone.
Yeah.
It was a pleasure.
Bye-bye. Thanks a lot.
Thanks.